If your doctor recently looked at your blood pressure reading and said the word perfect, I want you to pause for a moment before you feel too relieved, because there's a part of this story that almost never gets explained in a 15-minute appointment. This is Life Care Insights, and today we're talking about something that affects millions of older adults, but rarely gets the attention it deserves. The difference between a blood pressure number that looks good on paper and a blood pressure number that actually keeps you safe on your feet. Let me start with a story. We'll call her Margaret, 78 years old, sharp as ever, still driving herself to the grocery store and to church every week. She'd been managing high blood pressure for over a decade. Over the years, her doctor added one medication, then another, then a third, always working toward the same familiar target, 120/80. Each time her numbers came down, her chart reflected the same reassuring note, blood pressure well controlled. Margaret trusted the process, the way most of us do. We trust the number our doctor gives us, because why wouldn't we? Then one morning, a few months after her pressure had finally settled at a textbook perfect 122/76, Margaret stood up from her kitchen table, reached for her coffee cup, and the room spun. She lost her balance and fell, catching herself on the counter hard enough to fracture her wrist. When paramedics checked her blood pressure lying down, it was 118/74. When they checked it standing, it had dropped to 86/58. That's a difference of over 30 points in the top number, just from standing up. What happened to Margaret has a name: orthostatic hypotension. It means that when she stood, her blood pressure dropped sharply because her body couldn't adjust quickly enough to keep blood flowing steadily to her brain. She had mentioned feeling occasional dizziness to her doctor more than once, and each time it was noted as a normal part of aging, with the advice to simply rise slowly. No further testing was done, and no one connected it back to her medications. Margaret's wrist eventually healed, but something else didn't heal as easily. She became nervous in her own kitchen. She stopped driving. Her world quietly shrank down to the space between her bedroom and her living room couch. Months later, reduced mobility contributed to a bout of pneumonia, serious enough to land her in the hospital for over a week. She survived, but she never quite got back to the woman who used to drive herself to church every Sunday morning. Her daughter asked a question afterward that stuck with a lot of people who heard this story. How can a perfect blood pressure number do this to someone? That question is really the heart of what we want to unpack today, because Margaret's experience is far more common than most people realize, and understanding why can genuinely change how you and your doctor approach this conversation. For decades, the general message around blood pressure has been simple, and for most of our adult lives largely correct. Lower is better. If you're in your 40s or 50s, aiming for a tighter blood pressure target really does reduce your risk of heart attack and stroke, and that guidance is well supported by strong research. But something changes physiologically as we move into our 70s, 80s, and beyond, and the research behind many popular guidelines wasn't originally built with that older, more complex population in mind. Here's some important context. One of the most influential blood pressure studies of the last 2 decades enrolled a large group of adults over 50, with an average age around 68. Researchers compared an intensive treatment group aiming for a systolic pressure under 120 against a standard group aiming for under 140. The results made headlines: fewer heart attacks, fewer strokes, fewer cardiovascular deaths in the intensive group. That trial became the foundation for a lot of the aim for 120 inches messaging that's still repeated in exam rooms today. But there's a detail that rarely makes it into the headlines. That study excluded people with diabetes. It excluded anyone with a history of stroke, anyone living with dementia, anyone with advanced kidney disease, and anyone considered severely frail. In other words, the people who benefited most clearly from that aggressive target were by design some of the healthiest and least medically complicated older adults available for study. That's a very different group than the average person in their late 70s managing 2 or 3 chronic conditions on multiple medications. The same study also documented something else worth knowing. The intensive treatment group experienced meaningfully higher rates of dizziness, fainting, kidney complications, and falls serious enough to require hospital care. The cardiovascular benefit was real, but so was the added risk, and that trade-off tends to get lost by the time the message reaches a waiting room pamphlet. A separate large trial conducted in China a few years later, involving thousands of adults between 60 and 80, found a very similar pattern: better cardiovascular numbers in the lower target group, alongside more falls and more orthostatic symptoms. None of this means those studies were wrong. It means their findings answered a specific question for a specific group of people, and that nuance often gets flattened into a single blanket recommendation that gets applied to everyone over a certain age, regardless of how well that recommendation actually fits their individual situation. So why does the body respond so differently to blood pressure as we age? There are a few physiological reasons worth understanding. The first is arterial stiffness. Think of a garden hose that's been left coiled in a garage for 20 years compared to a brand new one. The old hose has lost its flexibility. Over decades, our arteries undergo a similar kind of stiffening. When the heart pumps blood into arteries that have lost some of their elasticity, they can't absorb the pressure wave the way they could when we were younger. This means the body sometimes genuinely needs a slightly higher baseline pressure to reliably push blood upward against gravity, especially the moment we stand. The second is a slowdown in something called baroreceptor sensitivity. Baroreceptors are small sensors located in our blood vessels that detect changes in pressure and signal the heart and blood vessels to adjust almost instantly. In a younger adult, this system reacts within milliseconds of standing up. As we age, these sensors respond more slowly. If someone's baseline pressure is already on the lower end and their baroreceptors have slowed down, the drop that happens the moment they stand can reach the brain before the body has had a chance to correct it. That's the lightheadedness. That's the moment the room seems to tilt. The third factor is how our bodies process medication as we age. Kidneys and liver function gradually change over time, meaning a dose that was well calibrated 5 or 10 years ago may behave differently. Now, staying in the system longer or having a stronger effect than the original prescription intended. A blood pressure reading taken while sitting comfortably in a doctor's office can look completely ideal while telling us nothing about what happens the moment that same person stands up in their own kitchen. This is exactly why a simple, at-home check can be so useful, and it takes only a few minutes. All you need is a home blood pressure monitor, which is widely available at most pharmacies for a modest cost. Lie down flat and rest quietly for about 5 minutes, then check your blood pressure while still lying down and write down both numbers. Then stand up right away and check again immediately, writing those numbers down as well. If the top number drops by more than about 20 points, or the bottom number drops by more than about 10 points upon standing, that pattern is worth bringing directly to your doctor's attention because it may indicate orthostatic hypotension, the same issue that quietly affected Margaret for months before her fall. This isn't a test that's meant to replace medical guidance or hand you a new target to aim for on your own. It's meant to give you real, useful information to bring into the conversation with your physician, the same way you'd bring in a symptom diary or a log of unusual episodes. Doctors work with limited time and limited data during a single appointment, and information like this can genuinely help them make a more personalized decision about your care. It's also worth understanding that one-size-fits-all rarely applies well to blood pressure management in older adults, because so much depends on individual context. Consider two people, both in their early 70s, both with an identical blood pressure reading of, say, 142/84. One of them is active, plays golf twice a week, has no diabetes, no prior heart events, and strong kidney function. The other has type 2 diabetes, a previous cardiac event, and reduced kidney function. Even though their starting numbers look the same, the safest path forward for each of them may look quite different, because their overall health picture, fall risk, and medication tolerance aren't the same. This is exactly why blanket numeric targets pulled from a single study population don't always translate cleanly to every individual sitting in an exam room. There's another number that tends to get far less attention than it deserves: the diastolic reading, the bottom number. For many older adults, keeping that number from dropping too low matters more than people realize, because when diastolic pressure falls too far, blood flow to the heart itself during its relaxation phase can become compromised. If your systolic number looks fine, but your diastolic reading consistently runs low, That's a detail worth raising directly with your doctor, even if nothing on the surface seems alarming. So what does this mean practically? It doesn't mean throwing out whatever target your doctor has given you, and it definitely doesn't mean adjusting your own medication based on numbers from a video. What it does mean is having a more informed, more specific conversation at your next appointment. Bring a 2-week log of your morning and evening blood pressure readings. Bring the results of the simple lying down to standing test described earlier. Mention any dizziness, unexplained fatigue, or brain fog, especially if it tends to happen after standing or shortly after taking your medication. These details are not simply normal signs of getting older. In the context of blood pressure treatment, they can be meaningful clues that your current target may need to be reconsidered for your specific situation. A good question to ask directly is this: given my age, my other health conditions, and the medications I'm currently taking, is my current blood pressure target still the right one for me? A physician who stays current with the research will welcome that question, and the information you bring with you is what makes that conversation genuinely productive, rather than just another rushed 15-minute visit. Coming back to Margaret, her story didn't end at the hospital. After her fall, her care team took a closer look at her full picture, and over time, 2 of her 3 blood pressure medications were carefully reduced. Her pressure settled at a slightly higher number than before, and her drop upon standing shrank dramatically compared to what it had been. Within several months, she felt steady enough to start driving herself again, including back to her Sunday church service. Her outcome didn't come from chasing the lowest possible number. It came from a more personalized approach that took her whole situation into account. Guided by her own doctor, using real information from her own body, the bigger takeaway here isn't a specific number to memorize or a target to chase on your own. It's the understanding that blood pressure guidelines, while built on real and valuable research, were designed around specific study populations that don't always mirror every person managing this condition later in life. Guidelines evolve slowly, and clinical practice sometimes takes time to catch up with newer research, which is exactly why being an informed, engaged participant in your own care matters so much, especially as we get older. If there's one thing worth taking away and acting on today, it's this: don't treat any blood pressure number, high or low, as automatically safe just because it matches a chart. Pay attention to how your body actually responds, especially when you stand up. Note any dizziness or lightheadedness, and bring that real, personal information to your doctor rather than assuming a single standard applies equally to everyone. You are not just a number on a page. You're a person with a unique history, a unique set of health circumstances, and you deserve a blood pressure target that reflects that, decided together with a doctor who knows your full story, not just your chart. That's it for today's episode of Life Care Insights. If this helped you understand something your last doctor's visit didn't have time to fully explain, share it with someone in your life managing blood pressure who might benefit from asking their doctor a more specific question at their next appointment. Taking a little extra time to understand your own numbers today could make a meaningful difference down the road.